Systemic juvenile idiopathic arthritis. So the most common arthritis is seen in the pediatric patients less than 12 years of age. Usually present with daily spiking fever, salmon pink macular rash, uveitis, arthritis, commonly 2+ joints. Okay, frequently present with leukocytosis, thrombocytosis, anemia, increase in ESR, and increase in C-reactive protein. Treatment is done with NSAIDs, steroids, methotrexate, tumor necrosis factor alpha. So this is the concept of systemic juvenile idiopathic arthritis. They sometimes test you on this concept in the step exams. So keep this concept handy. It is the most common arthritis seen in the pediatric patients who are less than 12 years of age. Okay, then we have next Sjogren's syndrome. It is a very commonly asked concept, that is autoimmune condition. So autoimmune disorder characterized by the destruction of exocrine glands, especially the lacrimal and salivary by lymphocytic infiltrates, predominantly affects the women 40 to 60 years of age. Causes a common primary disorder, or it can be a common primary disorder. Sjogren's syndrome can also be a primary disorder, or it can be secondary syndrome associated with other autoimmune disorders, for example, rheumatoid arthritis or systemic lupus erythematosus or systemic sclerosis. Findings: inflammatory joint pain, keratoconjunctivitis sicca, that is decreased tear production and subsequent corneal damage, because the nutrition of the cornea is coming from the tear film that is present on the interior surface. Like suppose this is the cornea over here. The tear film that is present on the cornea will give the required nutrients along with the oxygen that will be dissolved in this tear film, and that will be taken to the cornea, because cornea does not have a blood supply. Then keratoconjunctivitis sicca, because decreased tear production and subsequent corneal damage. Xerostomia, that is decreased salivary production, because we saw that it is the destruction of the exocrine glands. Exocrine glands are the ones which secrete the fluids via a duct. So when the exocrine glands are gone, so we are not going to have a saliva production. Then bilateral parotid enlargement will also be seen. So these are the 4 points. Then investigation: presence of anti-nuclear antibodies. Rheumatoid factor can be seen in the absence of rheumatoid arthritis. Anti-ribonucleoprotein antibodies, SSA, anti-Rho, or SSB, anti-La. Anti-SSA and anti-SSB may also be seen in systemic lupus erythematosus. Positive anti-SSA in the pregnant women with SLE will cause an increased risk of congenital heart block in the newborn. Focal lymphocytic sialadenitis on the labial salivary gland biopsy can confirm the diagnosis. Labial is for the lips and salivary gland. Okay, no, labial salivary glands are the minor salivary glands which are present on the lips as well. So focal lymphocytic sialadenitis on the labial salivary gland biopsy can confirm the diagnosis of Sjogren's syndrome. And this is the picture which you will get on the biopsy, that is lymphocytic sialadenitis. A lot of lymphocytes can be seen in the picture. Then complications include dental caries, because saliva is not being produced, because saliva was responsible for washing out of your teeth and stuff like that. Mucosa associated lymphoid tissue, that is MALT lymphoma, may be present as parotid enlargement. So the slide show of a classic focal lymphocytic infiltration in a minor salivary gland section stained with a hematoxylin and eosin. These findings are typical for the Sjogren's syndrome. Then we'll talk about septic arthritis. Septic arthritis is caused by, definitely as the name indicates, septic is for any organism or any infectious agent. So that can be Staph aureus, Streptococcus, Neisseria, gonorrhea. They are common causes. Affected joint is swollen, red, and painful. Synovial fluid purulent, like WBC count will be more than 100,000 per millimeter cube with absent crystals. So leukocytosis without crystals is septic arthritis. Leukocytosis with crystals is either gout or pseudo gout. Gonococcal arthritis, it is a sexually transmitted infection that presents as either purulent arthritis, for example knee, or triad of polyarthralgia, tenosynovitis, and dermatitis. Gonococcal arthritis can present as either the purulent arthritis of the knee or a triad of polyarthralgia. One. Second component of the triad is tenosynovitis, for example in the hand, and number 3 is dermatitis, for example the pustules which are found. Synovitis, characterized by pain, erythema, swelling, and reduced range of motion in a joint. Acute synovitis may represent serious pathology, for example septic arthritis, especially if accompanied by fever or leukocytosis. It should be evaluated urgently with synovial fluid analysis. What is systemic lupus erythematosus? The mnemonic for that is rash or pain. That is, these are the findings which we get in a woman with lupus erythematosus, because mostly it affects the women. It can affect the men as well, because it is an autoimmune condition and immune system is common to both men and women, but all of the autoimmune conditions are for some reason present more in the women. So rash or pain. Rash means rash, malar or discoid rash, we'll see the pictures of that. Arthritis, that is non-erosive arthritis. Serositis, that is pleuritis, and pericarditis, these are the serous membranes which can be inflamed. Hematologic disorders, for example, cytopenias. Then oral or nasal ulcers, usually pain-less oral or nasopharyngeal ulcers will be found. Renal disease can be there. Photosensitivity, anti-nuclear antibodies, immunologic disorders, for example, anti-dsDNA, anti-Smith and anti-phospholipid antibodies can be found. Anti-phospholipid antibodies are hypercoagulable state. Then we have neurologic disorders, for example, seizures and psychosis. Lupus patients die with redness in their cheeks. So that's a mnemonic to bring you to the mnemonic that the patients who have redness like a malar rash, butterfly malar rash, will go from here to here like that, from one side of the face to the other. So that is the butterfly rash. Okay, we'll see the picture of that as well. But remember, the butterfly rash is present in the case of systemic lupus erythematosus. Now let's see the discussion, the pathogenesis. Systemic, remitting and relapsing autoimmune disease. Okay, so it is systemic, like multi-systems involvement will be seen. It is remitting. Remitting means that it can be resolved and then come later on as well. And relapsing, that there are episodes, like it is episodic. So remitting and relapsing means that it is an episode. It comes and goes in an episodic fashion. That there will be an episode of remission, like nothing is there, and then there comes an episode where flaring occurs and severe exacerbation of the disease takes place. So it waxes and wanes, you may say that. Organ damage primarily due to type 3 hypersensitivity reaction, to a lesser degree a type 2 hypersensitivity reaction. Type 3 hypersensitivity reaction means that there are immune complex deposition in multiple areas. Like we talked about antibodies, anti-double stranded DNA. Suppose that there we have a cell, like let's talk about the pathogenesis and how the immunity develops. There was some apoptosis or necrosis of a cell at some place, and the DNA fragments were free to move in the body. And in the susceptible people, these DNA fragments, because most of the DNA, almost all of the DNA is present inside the cell. No DNA is present in the serum or in the plasma. If the DNA is free to float, the immune system will detect these as foreign proteins or foreign antigens, and they will start forming antibodies against them. Now more the DNA floating, more will be the antigen antibody complexes that will be forming. Resultantly, these antigen antibody complexes will start depositing in different areas. For example, in the joints will causing polyarthralgia. For example, in the skin they will be causing rash and stuff like that. So that is type 3 hypersensitivity reaction, and this is the main culprit of all these symptoms in the case of systemic lupus erythematosus. But it can also be a type 2 hypersensitivity reaction, that is antibodies against particular antigens is being formed. For example, the antibodies against RBCs may be there, the antibodies against particular cell membrane agents may be there, that is called as anti-phospholipid antibodies. So that is type 2 hypersensitivity, but the main role is played by the type 3 hypersensitivity associated with the deficiency of early complement proteins, that is C1q, C4 and C2. Now you can see that immune complex deposition in either of the two conditions, the complement is activated, and if there is over activation of the complement, there will be hypocomplementemia, that is C1q, C4 and C2, decreased clearance of the immune complexes. Classic presentation: rash, joint pain and fever in a female of reproductive age, especially the African American or Hispanic descent. Libman-Sack endocarditis or LSE. So in SLE you find LSE, that's it, LSE in SLE. Non-bacterial verrucous thrombi, usually on the mitral or aortic valve, and can be present on either surface of the valve, but usually on the undersurface. That is very important, that normally these vegetations are present on the superior surface of the valve, but in the case of Libman-Sack endocarditis, either of the two upper and lower surfaces can be involved, but usually it is on the undersurface. And LSE in SLE. Okay, lupus nephritis, glomerular deposition of the DNA anti-DNA immune complexes. Again, it is a type 3 hypersensitivity mechanism. The DNA anti-DNA immune complexes are deposited in the glomerular base, in the glomerulus. It can be nephritic or nephrotic. Nephritic means, okay, so we'll start with nephrotic. If there is only proteinuria, that is nephrotic. If proteinuria is associated with the hematuria as well, with the RBC casts and stuff like that, now it has become nephritic, causing hematuria or proteinuria. Hematuria for nephritic and proteinuria for nephrotic. Most common and severe type of diffuse proliferative. So it can either be membranous nephropathy, that is a nephrotic syndrome, that is a relatively benign condition in comparison to the diffuse proliferative condition, which is either only nephritic or mixed, that is nephritic nephrotic condition. Common cause of death in systemic lupus erythematosus: renal disease, most common, infectious, cardiovascular disease, accelerated coronary artery disease. Moving forward, we'll talk about drug-induced lupus erythematosus. So these are some drugs which can cause lupus erythematosus. Implicated drugs are procainamide, hydralazine, isoniazid, minocycline and TNF-alpha inhibitors. Talking about the features of the drug-induced lupus erythematosus, the clinical features are Abrupt onset of symptoms, for example, fever and fatigue and arthralgia or arthritis, rash, serositis, predilection for slow acetylators. So the people who are slow acetylators, who cannot acetylate the drugs, because acetylation is a mechanism of removal of the drugs. If the people who are slow acetylators, they are not able to remove these drugs or some of these drugs. So for example, isoniazid, they cannot remove that drug easily, or very fastly. So they are slow acetylators, so slow removing of the drug takes place. If the dose is not tapered according to the subjective needs, so that can cause toxicity, and toxicity may result in the development of lupus erythematosus. Okay, there are a lot of other drugs as well. For example, TMP SMX is also a causative agent for the lupus erythematosus, and there are a lot of other drugs as well. But remember these ones, these are high yield. Lab findings: antihistone antibodies present in more than 95% of the patients. Anti-double-stranded DNA antibodies rarely seen, specific for systemic lupus erythematosus. So antihistone antibodies present in more than 95% of the patients, and that is not specific for the lupus. They are present in a lot of other conditions as well. Anti-double-stranded DNA antibodies are rarely seen, and they are very specific for the SLE. So remember that in the drug-induced lupus, anti-DNA antibodies may not be found, but you have to make the clinical diagnosis. Then we have, unlike classic lupus, the drug-induced lupus erythematosus typically lacks the usual cutaneous manifestations. That is very important, because whenever I think of lupus nephritis, the only thing that comes to mind is the malar rash. But in the case of drug-induced lupus erythematosus, the malar rash is absent and is rarely associated with the neurologic or renal complications. Clinical improvement is rapid or discontinuation of the causative agents. Procainamide, hydralazine, and isoniazid are metabolized by phase 2 acetylation in the liver. Genetically predisposed individuals who are slow acetylators are at greater risk for developing the drug-induced lupus erythematosus. Patients who are slow acetylators are also predisposed to isoniazid-induced peripheral neuropathy due to increased drug concentrations. Then we'll talk about antiphospholipid syndrome. So it is antiphospholipid syndrome is a hypercoagulable state. Okay, so primary or secondary autoimmune disorder most common in systemic lupus erythematosus. Features of antiphospholipid syndrome: clinical, venous or arterial thromboembolic disease. So since it is a hypercoagulable state, so it will result in deep vein thrombosis, pulmonary embolism, or ischemic stroke or transient ischemic attack. Adverse pregnancy outcome can be unexplained embryonic or fetal loss and premature birth due to placental insufficiency or preeclampsia. So think about it like that, because it is a hypercoagulable state. So resultantly, if there is any thrombosis that is happening in the placental vessels, or maybe inside the fetus in the umbilical veins or stuff like that, in that case the fetus is not gaining or receiving enough oxygenation, and the nutrition and the metabolic demands are not being met. In that case, there may be unexplained embryonic or fetal loss, and premature birth due to the placental insufficiency or preeclampsia can occur. Lab values: lupus anticoagulant effect. So labs may show paradoxical anticoagulation in this hypercoagulable state. Paradoxical APTT, or that is a measure of intrinsic factor incapability. So paradoxical APTT prolongation not reversed by addition of normal platelet free plasma. So in the labs we get APTT. That is why we call it anticoagulant effect. So lupus anticoagulant syndrome, it is also called a lupus anticoagulant syndrome, but practically, as seen in the patient, it is a hypercoagulable state. So the lupus antiphospholipid antibodies or the lupus anticoagulant syndrome is basically a hypercoagulability syndrome. That's a paradox, but remember that. False positive VDRL or RPR can also be seen. So these are the tests for syphilis, and in the case of antiphospholipid syndrome, these tests also come out to be positive. Presence of specific antiphospholipid antibodies, anti-cardiolipin antibodies, and beta-2 glycoprotein 1 antibody, they are also seen in these conditions. Then we'll talk about mixed connective tissue diseases. Features of systemic lupus erythematosus, systemic sclerosis, and polymyositis. It is associated with anti-U1 ribonucleoprotein antibodies, speckled anti-nuclear antibodies. Okay, so anti-U1 ribonucleoprotein, there is a page, will soon cover the immunology section inshallah. So in that there is a page on which all the antibodies are mentioned, so don't worry about them. So but remember that in the case of mixed connective tissue disease, we have anti-U1 ribonucleoprotein antibodies or speckled anti-nuclear antibodies. Then we'll talk about polymyalgia rheumatica. Polymyalgia means multiple areas of muscle pain, and rheumatic, I guess, in the joint pain. So symptoms: pain and stiffness in the proximal muscles, for example shoulders and hips, often with fever, malaise, and weight loss. Does not cause muscular weakness. Muscular weakness is not there, but there is muscular pain. Myalgia means pain. Then we have more common in the women more than 50 years of age, associated with a giant cell temporal arteritis. Findings: increased ESR, increased C-reactive protein, and normal creatine kinase. Treatment is with a rapid response to the low dose corticosteroids. Giant cell arteritis. Giant cell arthritis symptoms are systemic, which are fever, fatigue, malaise, and weight loss, headache, jaw claudication, visual disturbances, for example, ischemic optic neuropathy, and polymyalgia rheumatica. Diagnosis is done with the elevated erythrocyte sedimentation rate and C-reactive protein. The temporal arthritis biopsy or temporal artery biopsy, temporal artery biopsy will show intimal thickening, elastic lamina fragmentation, multinucleated giant cell. Treatment is done with the glucocorticoids. So glucocorticoids are a treatment of almost all the autoimmune conditions, but you have to use them judiciously because glucocorticoids themselves have a lot of side effects which are not tolerated by a lot of patients. So whenever you are going to use glucocorticoids, check for the safety profile first. Then Uworld point is cell-mediated immunity is the primary mechanism underlying giant cell arthritis. The production of cytokines, in particular interleukin 6, is an important driver for the process and closely correlates with the severity of the symptoms. A monoclonal antibody against interleukin 6, that is tocilizumab, is effective in treating the giant cell arthritis. Then fibromyalgia. Fibromyalgia is dysregulated neurotransmitter function. Fibromyalgia is caused by dysregulated neurotransmitter function, leads to abnormal central processing of painful stimuli, and that is commonly seen in the women 20 to 50. So the fibromyalgia is basically a condition in which there is abnormal central processing of painful stimuli. I guess there is an exaggerated feeling of the pain without the pain actually being there. Symptoms: there is widespread musculoskeletal pain, fatigue, impaired attention and concentration, psychiatric disturbances, for example depression and anxiety, symptoms lasting for more than or equal to 3 months. Physical examination will show multiple tender points at characteristic locations, absence of joint or muscular inflammation. Lab findings will show normal acute phase reactions, for example ESR and CRP, and other inflammatory markers. So it is different from polymyalgia rheumatica in a sense. The polymyalgia rheumatica will have elevated ESR and C-reactive protein, and manifestations are somewhat similar. In the case of fibromyalgia, there is dysregulation of the neurotransmitter leading to abnormal central processing of painful stimuli. So there will be ESR and CRP are very normal, and other inflammatory markers are also normal, but the physical examination shows multiple tender points at the characteristic locations, and inflammation is not seen. So remember this thing. So this is the differential point between the fibromyalgia and polymyalgia rheumatica, but the point is that almost all of the autoimmune conditions have pretty much similar findings. Like all of them will be presenting with a joint pain, all of them will have elevated CRP. Fibromyalgia does not have that, but most of them have elevated CRP as well. Some kind of antibody is also present in them, and women are most commonly involved, and women of more than 50 years are commonly involved. So this is the basic blueprint of all the autoimmune conditions, whatever may be. And then we have to go for the particular findings. These I guess are not very high yield, so read them, remember them as far as you can, but not use too much of your brain energy in remembering every particular detail of every autoimmune condition, because they are not going to be asked on the step 1 exam. Then we'll talk about the treatment. So the treatment: low impact aerobic regular exercise. Although exercise can temporarily exacerbate the pain of fibromyalgia, gradual incremental aerobic exercise is proven to reduce the pain and improve the function. Antidepressant, tricyclic antidepressant and SNRIs modify the processing of the pain signals. Anticonvulsant, for example pregabalin, and neuropathic pain agents, for example the gabapentin, avoid opioid and corticosteroids. So here now you can see the pain points. It can be in the, if we see anteriorly, low cervical, second rib, lateral epicondyle of the humerus, the knee joint. These are the characteristic points on the anterior surface, on the anterior part of the body, and moving to the posterior part of the body: occiput, trapezius, supraspinatus muscle, gluteal muscles, and the greater trochanter. These are the characteristic sites on the posterior surface. So anterior and posterior surfaces have these findings. Then we'll talk about polymyositis and dermatomyositis. Lab values are increased keratin kinase, positive anti-nuclear antibodies, which are non-specific. Anti-nuclear antibodies are non-specific. They will be elevated in a lot of conditions. Positive anti-Jo1, histidine tRNA synthetase, and specific. Okay. So for polymyositis and dermatomyositis, the anti-Jo1 antibodies or histidine tRNA synthetase are very specific. Anti-SRP, they are also specific. Anti-MI2 specific antibodies. So these three are specific, while increased keratin kinase and positive anti-nuclear antibodies are not specific. So firstly, you will do this test. You will suspect that there might be polymyositis or dermatomyositis. Then you go to the specific test. Both disorders are associated with the interstitial lung disease. Treatment: steroid followed by the long-term immunosuppressant therapy, for example methotrexate. Okay. Then polymyositis. Now we'll talk about both of these conditions individually. Polymyositis, the presentation is progressive symmetrical proximal muscle weakness. The proximal muscle weakness is there. Symmetrical and proximal muscle weakness most often involves shoulder but no skin involvement. That is the differential point for systemic lupus erythematosus that even the systemic lupus erythematosus, we find some sort of proximal muscle weakness, but the skin involvement is not present in the polymyositis. Histology of the muscle biopsy: endomysial inflammation, CD8 positive T cell infiltration. Polymyalgia rheumatica may present similarly. Okay, so polymyalgia rheumatica can also present similarly. I guess I was confusing that with systemic lupus. So the polymyalgia rheumatica can also present as with similar symptoms to the polymyositis. However, muscle biopsy is normal in polymyalgia rheumatica, while in this case you will find the CD8 positive infiltrates. So on the clinical grounds, if you have a woman more than 50 years of age with joint pains, proximal muscle weakness, so you can diagnose any of the two conditions, because at the end of the day you are going to prescribe glucocorticoid for both the conditions. So you're not supposed to be worried about that. But for the step 1 exam, if they're giving you a biopsy along with the proximal muscle weakness, then think about polymyositis. Dermatomyositis, clinically similar to polymyositis. As you can see, these conditions are very similar to each other. So clinically similar to polymyositis, but also involves malar rash. That makes it similar to systemic lupus erythematosus. Similar to that in the systemic lupus erythematosus, but involves nasolabial folds. It has guttural papules, that is very specific. These are violaceous papules over the metacarpophalangeal and proximal interphalangeal and distal interphalangeal joints. Heliotrope rash, that is violaceous periorbital rash. Shawl and face rash. Okay, do we have pictures of that? I guess we have pictures. So these are, the guttural papules, and these are guttural papules over here. Then the heliotrope rash, I guess it is over here, maybe, I don't know. So we'll see that. So the heliotrope rash, that is violaceous periorbital rash. Then shawl and face rash, darkening and thickening of the fingertips and sides resulting in the irregular dirty appearing marks. Okay, darkening and thickening of the fingertips and sides resulting in irregular edges, maybe. Okay, increased risk of occult malignancy, for example the gastric carcinoma. Dermatomyositis can be associated with the gastric carcinoma. Histology: perimesial perifascicular inflammation, that is perimesium closer to skin. So perimesial and perifascicular inflammation. Perimesial means that these are basically muscle coverings. Fascicle, so perimesium is closer to skin, which means that the muscles are muscle fibers, they are clustered together in fascicles. So the layer that is covering those fascicles, that is called as perifascicular perifascicular covering. So that covering can be inflamed, like that is perifascicular inflammation. Or perimesium is the covering that is involving whole of the muscle. Multiple fascicles are covered inside this perimesium. So if the perimesium is inflamed, perimesium is closer to the skin, that can also be found in this condition. Atrophy with CD4 positive cell infiltration. In the polymyositis, there was CD8 positive cell infiltration. So how will you say that? If it is P, if we make another buzz downwards, it looks something like an 8. So that is why it's CD8. And dermatocyte A, B, C, D. D is the fourth letter of the alphabet, so it is CD4 positive. Okay, such a pathetic mnemonic is that. Okay, diagnosis. Serologic markers are anti-Jo1, anti-MI2 positive, anti-P155 and anti-P140 positivity, and anti-signal recognition protein or SRP positivity. So we'll see these antibodies which are found in different conditions. Okay, so I guess this is heliotrope rash, the periorbital rash, and this one too. Okay, so anti-Jo1 antibodies, interstitial lung disease, non-erosive arthritis, and mechanic hands skin rash. Anti-Jo1 antibodies are found in they are found in polymyositis, dermatomyositis, both of them. So these are mechanical hand rash. This one, these are associated with the dermatomyositis and polymyositis. All of these are associated with dermatomyositis and polymyositis. Anti-MI2 positive, guttural papules and heliotrope rash. So here you can see guttural papules. Okay, so this one is mechanic hand skin rash. I guess the same thing. Okay, guttural papules and heliotrope rash and guttural papules. Anti-P155 and P140, paraneoplastic and juvenile cases, and anti-signal recognition protein SRP positive. Prominent muscle weakness and atrophy will be seen if this antibody is present. Then we'll move forward to the X-linked muscular dystrophy. The X-linked muscular dystrophy, it has some very characteristic findings. We'll see that degenerative disorders characterized by the muscle wasting and replacement of the skeletal muscle by adipose tissue. So there will be muscle wasting and replacement of skeletal muscle by adipose tissue due to mutation in the protein dystrophin. Okay, dystrophin is important for anchoring the muscle cytoskeleton to the extracellular matrix. So basically, this is muscle and it has a cytoskeleton. Cytoskeleton is the actin and myosin chains which are giving the cell its architecture, and then we have extracellular matrix. So the dystrophin is connecting the muscle fibers, intracellular cytoskeleton to the extracellular matrix, which gives the muscle its proper shape. Okay, and that is important for the life of the muscle. Mutation are often spontaneous. Large gene size predispose to high rate of mutation, and that is why if the connection is not there, the muscle fiber, the integrity of muscle fiber is lost, and the muscle fiber undergoes apoptosis. Duchenne muscular atrophy is due to deletion of that dystrophin. So D is for the Duchenne and D is for the deletion. So in the Duchenne muscular dystrophy, we'll find deletion of the dystrophin. It presents as proximal muscle weakness at first year of age, progressively progresses to involve the distal muscles. Calf pseudohypertrophy is a characteristic finding. So calf pseudohypertrophy, here you can see that the calf muscle are super hypertrophied in this case. So calf pseudohypertrophy is a characteristic finding. Serum creatinine kinase is elevated. Death results from cardiac or respiratory failure. Myocardium is commonly involved. So the cause of death is myocardium. The cause of death is cardiac or respiratory failure, and myocardium is commonly involved. So this particular finding is the Gower sign that is found in the case of Duchenne muscular dystrophy. That is an X-linked dystrophy. So if it is X-linked, X-linked what? X-linked recessive condition. I guess it is X-linked recessive. Yes, they are X-linked recessive conditions, and that is why they are more common in the boys. Or not more common, they are found only in the boys, because all the X-linked recessive conditions are found exclusively in the boys. So here you can see this is Gower sign. When the child wants to stand up or walk, so he will first go to this position, then he will stand with the help of his arms, and then he will push his knees backwards to stand in this position, using hands to push the legs to stand, and then even when he stands look something like this on his toes. So this is thigh atrophy and calf hypertrophy. That is Gower sign. Becker muscular dystrophy due to the mutated dystrophin. Okay, so for the Duchenne, D means deletion of the dystrophin, right? And for the Becker, we have only mutated dystrophin clinically result in the milder disease. Okay, so common causes of myopathy, these are some common causes. First one, glucocorticoid induced myopathy, progressive proximal muscle weakness and atrophy without pain. Lower extremity muscles are more involved, and the keratin kinase will be normal because it is a drug induced condition. Secondly, not only drug induced condition, if somebody has Cushing disease or something like that, so there will be glucocorticoid induced myopathy. Polymyalgia rheumatica is a second condition. There will be muscle pain and stiffness in the shoulder, neck and pelvic girdle, worse in the morning and with activity. So polymyalgia rheumatica is worse in the morning and also with activity, and it resolves with the rest probably. The creatine kinase is again normal. Inflammatory myopathies, for example, polymyositis and dermatomyositis, proximal muscle weakness, skin rash and inflammatory arthritis may be present, and keratin kinase will be elevated. Statin induced myopathy, proximal muscle pain and weakness usually within weeks to months after starting statin, and keratin kinase is also enhanced. Hypothyroid myopathy, muscle pain, cramps and weakness involving the proximal muscles, delayed tendon reflexes and myoedema, and features of hypothyroidism is also present in the case of hypothyroid myopathy. Then the keratin kinase will be elevated. So keratin kinase is elevated in the case of inflammatory myopathy, statin induced myopathy, and the hypothyroid myopathy, and the glucocorticoid and polymyalgia rheumatica, the keratin kinase is normal. Characteristic patterns of muscular atrophy. They can be neurogenic, dermatomyositis, disuse or prolonged corticosteroid use, and spinal muscular atrophy. So neurogenic is a cluster or group of atrophic fibers will be seen in the neurogenic muscular atrophy, for example, in the case of lower motor neuron type of injury. So in that case, the muscle fibers, they will undergo atrophy because of neurogenic loss of the nerve supply, because the trophic signals are being given by the nerves or the lower motor neurons. They are lost, so there will be atrophy, and a group of atrophic fibers will be found. In dermatomyositis, there will be perifascicular atrophy. In the disuse or prolonged corticosteroid use, type 2 fiber atrophy and type 1 fiber sparing. So type 1 fibers will be spared, which are the postural muscles, while the type 2 fibers, which are the white muscle fibers or the fibers which you use for the bodybuilding and stuff like that, so they will atrophy, but the type 1 will be spared in the case of disuse or prolonged corticosteroid use. And spinal muscular atrophy, panfascicular atrophy. Then the clinical disorders by defect or mechanism. So neuromuscular junction presynaptic defects, for example, Lambert-Eaton myasthenic syndrome and botulism. In the Lambert-Eaton myasthenic syndrome, suppose this is, we'll see that, but suppose this is the presynaptic nerve terminal and here we have the muscle. So the calcium channels which are present in the presynaptic nerve terminal, the antibodies are directed against that in the myasthenic syndrome. In the case of botulism, the botulism toxin will degrade will act as a snare protein, will that is a protease, and that will degrade the snare proteins, and that will not allow the acetylcholine filled vesicle to fuse with the membrane and to release the acetylcholine into the neuromuscular junction. That is a condition that we find in the botulism. Neuromuscular junction post-synaptic will be seen in the myasthenia gravis. So what are the mechanism of action in the myasthenia gravis? In the myasthenia gravis, you find that yes. So myasthenia gravis, if this is the presynaptic neuron and here we have the muscle, so in the post-synaptic muscular or the neuromuscular junction, after the in post-synaptic area, there are the nicotinic receptors against which the antibodies are directed. This is the mechanism of action or the mechanism of pathogenesis of the myasthenia gravis. Then we have action potential generation, myotonia and periodic paralysis. Action potential generation, the problems with action potential generation are seen in the myotonia and periodic paralysis. The excitation contraction coupling problems are seen in the malignant hyperthermia. Excitation contraction coupling is all that mechanism like when from the point of impulse, from the point when the impulse reaches the cell to the point when the contraction occurs, the process that occurs in between that, the whole process which we studied over here. Just give me a second. The physiology section. There, okay, that's way over it. So the physiology section which we saw, that this one, okay. So this is for the cardiac muscle. So it is excitation contraction coupling from this point all the way to the contraction that was happening over here. So if there is any problem with that, this thing is seen in the case of excitation contraction coupling problems are seen in this with this mechanism. Then we have then we have energy production. Energy production problem is seen with the McArdle's disease, phosphofructokinase disease, and some mitochondrial myopathies. Linkage contraction with the extracellular matrix, Duchenne-Becker muscular dystrophy, which we have just seen, Duchenne-Becker muscular dystrophy, and limb-girdle muscular dystrophy. So these two conditions are associated with a linking contraction with the extracellular matrix. Okay. Then we have neuromuscular junction diseases. Okay, at the neuromuscular junction there can be a lot of diseases. For example, black widow spider bite. Massive acetylcholine release leads to the depolarizing paralysis. So black widow spider, the massive acetylcholine release lead to the depolarizing paralysis. Okay, so first one is black widow poisoning. Then we have organophosphate poisoning. Permanently inhibit the acetylcholine esterase by phosphorylating the serine residue. Okay, serine residue is permanently phosphorylated, and acetylcholine esterase is thus inhibited. Phosphorylated cholinesterase may undergo a dealkylation reaction of the organophosphorus moiety, leading to the aged enzyme, that is conversion of the inhibited enzyme into a non-reactivable form. So the organophosphates are associated with the aging. If we found the patient and if we cured him before aging with the pyrrolidoxime, so we can reverse the process. But if the enzyme has once aged, then it is supposed to die. It will not be reversed. Once aging occurs, it becomes irreversible. About 8 hours with the pesticide or 20 minutes with the biological weapons causes depolarizing paralysis associated with the farmer, migrant workers, and suicide attempts. Presentation mnemonic is sludge, salivation, lacrimation, urination, diarrhea, GI motility, emesis, and also meiosis. I guess the dumbbells is also applicable in this condition because it is depolarizing. So maybe because it is a pro-cholinergic effect, salivation and lacrimation, urination, diarrhea. But remember, sludge is better because dumbbells does not make any sense, but this is making, because that is the wrong spelling, dumbbell something. Salivation, lacrimation, urination, diarrhea, GI motility, and emesis, also meiosis. The treat with removing the exposure. So first thing is to remove the patient from the site of exposure, be it a field with pesticides or be it a war zone with biological weapons. Soiled clothing, wash the skin with the soap and water. Airway control and mechanical ventilation. Cardiac monitoring. Pyrrolidoxime if aging has not occurred, and you must also administer the atropine. Botulism, myasthenia gravis, and Lambert-Eaton syndrome. So these are the conditions. Neuromuscular junction diseases can be black widow spider bite, organophosphate poisoning, botulism, and myasthenia gravis and Lambert-Eaton syndrome. So this is the difference between these two conditions, and that is very, very high yield because they often test you on the myasthenia gravis, and when they want to test you on the myasthenia gravis again, they may give you scenario like with Lambert-Eaton syndrome, so that to test if you know this thoroughly or not. Frequency of the myasthenia gravis, most common neuromuscular junction disorder. Pathophysiology, autoantibodies to the post-synaptic acetylcholine receptor, reduced motor end plate potential. Clinical, ptosis, diplopia, weakness, respiratory muscle involvement can lead to dyspnea, worsens with muscle use. improvement after androphonium tensilone test. So when we give the androphonium, there will be improvement because androphonium is it is also acetylcholinesterase inhibitor, and if we give the androphonium, so there will be positive tensilone test, and improvement will be seen. With muscle use, symptoms will worsen associated with a thymoma, thymic hyperplasia, and acetylcholinesterase inhibitor administration reverses the symptom. For example, androphonium to diagnose and pyridostigmine to treat, and that is an important point because in neuromuscular junction, in the myasthenia gravis, we have non-depolarizing muscle paralysis, because suppose these are the nicotinic receptors which are not getting acetylcholine at all, so they will be paralyzed. If we give them androphonium, so some of the acetylcholine that is present in the synapses will not be destroyed, and that will reach the nicotinic receptor more often, and that will ameliorate the symptoms. There is a similar condition that is called as cholinergic crisis, in which there is so much acetylcholine in the synapses that the nicotinic receptors become super saturated or super angry, and they make the cell paralyzed. So that depolarizing sort of paralysis is seen with this condition that is called cholinergic crisis. To differentiate cholinergic crisis from the myasthenia gravis, which present with a similar symptoms, we have to do the tensilone test. If administration of the androphonium ameliorates or makes the condition better, that is myasthenia gravis. If the androphonium administration worsens the condition, so that is cholinergic crisis. But we are not supposed to kill the patient by giving them androphonium, because the current symptoms are due to the acetylcholine. On top of that, we are giving acetylcholinesterase inhibitor. So why do we give androphonium to them? Because androphonium is a very short acting drug, and the total effect of the androphonium is gone after 15 minutes. So we can test it. That is why we are using the androphonium only for the diagnostic purposes, and then we use pyridostigmine to treat the patient. Lambert-Eaton myasthenic syndrome frequency, it is very uncommon condition, and all the uncommon conditions are highly tested on the step 1 exam. Secondly, pathophysiology, autoantibodies to the presynaptic calcium channels, and there will be decreased acetylcholine release. Clinical, proximal muscle weakness. Okay, eyes are usually spared, so the involvement of eyes, they're giving you hints about myasthenia gravis, and then they say that the person is better in the morning, but as for by the end of the day or in the evening, the person is so tired that he or she cannot even move. So that is myasthenia gravis. Autoimmune symptoms, dry mouth, impotence, and improves with the muscular use. With the muscle use, symptoms will improve. That is also a very high and important differential point, that for the myasthenia, the symptoms worsen with movement, but for the Lambert-Eaton, the symptoms improve with movement. Why so? Because there is problem with the presynaptic calcium channels. The more a person moves, the more will be the release of the vesicles, and more. Okay, listen. The more movement is there, slowly but steadily, more and more calcium enter the presynaptic terminals, and more acetylcholine is released, and by the midday, the person has done so much movement that enough acetylcholine has reached the synapses, and the person feels better. It is associated with small cell lung cancer. This association is very, very high yield. That thymoma and thymic hyperplasia is associated with the myasthenia gravis, and the small cell lung cancer is associated with the Lambert-Eaton syndrome. Then, so Lambert-Eaton L is for the lungs. So the condition that was present in the lungs is present in the Lambert-Eaton syndrome, and for the myasthenia gravis, remember the thymoma is present with that. And the acetylcholinesterase inhibitor administration will have minimal effect, because we are not having a problem with the acetylcholinesterase in the synapses. The acetylcholinesterase in the case of Lambert-Eaton is not being released at all. So remember this thing, and we'll see you in the next session. Until then, Allah Hafiz and fi amanillah.